We have a number of questions online. The first one here is something for both of you, I think. I was told there wasn't enough tissue from my biopsy to carry out molecular profile. What's the best thing to do?
Yeah, one third of patients unfortunately get that answer, I would say, 20 to 30%. So rebiopsy. A new material needs to be taken.
Yeah, the only thing I would add is that we have historically been using an approach of taking the bare minimum to get the diagnosis. Let's just confirm they've got cancer, send them off to the oncologist. I think one of the things that we're trying to do through the MDT is to make sure that if we know that we're going to need to do molecular profiling of a patient, when you're in there, the patient's got the local anesthetic in, you're putting a needle in to take a biopsy, take two. We're going to need that tissue. So we should be, as clinicians, kind of pushing for that good, sufficient tissue the first time. But you're right, Heinz-Josef, very often people have to go back and have a new biopsy. But we need to try and avoid that.
And if I may add, so the ERCP used to be just with cytology, but now there is lots of improvement with histology as well.
Okay. So another one that is very interesting is about, again, the molecular profiling. Are there standard gene panels which are globally accepted for molecular profiling for cancer, specifically for BTC? So which panels, which number of genes?
So far I'm aware that there's only a institutional decision on that. So my institution takes the panel which we can also use in the so we have in the Netherlands a program called the DRUP. I presented that last year, where we have drugs available for certain mutations or amplifications. So we use those we can actually do something with. But as I say, it's work in progress because changes are made every day, more or less.
Yeah, I think a few issues to raise here. All panels are not the same. And so it's important that people understand exactly what their panel is telling them and what's being tested for. In general, we don't have a cholangiocarcinoma specific panel. So there will be cancer panels, and these will need to cover most cancers: lung cancer, breast cancer, bowel cancer, and so on. And we need to make sure as a community that as we identify some new alterations, we make sure that the panels that are being used are including the genes that we're interested in. The other thing, and maybe John, our chair, might be able to answer this in more detail, but within the UK, the genomic laboratory hubs don't have a standardized panel. So they all have different panels, and they will report to you the specific mutations for which we have treatments. And so sometimes alterations are identified, but they won't necessarily be reported, as we don't have a particular treatment for that in the UK. And I know this is something that we're all trying to work on as a community to make sure that we get out the information that we need to make decisions. I don't know, John, if you want to just comment on that.
Yeah, the genomic tests, NHS genomic tests, should be done in the UK, are done in the genomic laboratory hubs, of which there are 7 in the country. And they will all do what's on the national directory, which is a list of targets that they must provide for every patient. You must know that for every single patient. How they do that is currently completely up to them. So the range of different tests through the country differ quite significantly. There's a move to try and standardize that and make the playing field a bit more even. But currently, it's still a bit of a mess. And so that's sort of in progress. But the tests are getting better and better the whole time. So everybody gets a DNA test and an RNA test. They find slightly different things, and particularly for this cancer, particularly for cholangiocarcinoma, you probably need both for most types of it. and that adds to the complexity of it and the requirement for tissue. The other huge advance is, of course, a liquid biopsy, and we're going to hear from Noreen Starling about that a bit later on, and that just, particularly for people without tissue, that's an option that may be considered, but there are lots of ifs and buts. We'll hear all about that a bit later.
And if I may add, the one subject we haven't raised yet at all is the reporting, because the tests are done and reporting can be varying by, it's very easy to read even if you're not a specialist or you have no clue what they actually say. And so that also needs to be put in consideration, because sometimes a doctor might not be experienced, get a result and has actually no clue what it means. And that is from the doctor's side a wish.
Thank you. So we have a question, Helen. Helen?
Thank you very much. Well, John's just touched on what I want to ask, and it's really to both Heinz Josef and Juan, and thank you both for really incredibly informative and, for me as a layperson, easy to understand presentations. But where you may struggle to get good biopsy tissue, it's all very well saying, you know, we'll take more, but that's sometimes, I understand, that is really not possible. And so where there is insufficient tissue, or to avoid the need for a second biopsy, what are the thoughts in the Netherlands? What are the thoughts in the UK about liquid biopsy?
Well, I have asked my lab if they can routinely do liquid biopsy testing, not only taking the blood, but also the testing. And the answer was no, we have not validated the tests yet. So it's all based on research projects. So we are ambitious, but we haven't done it yet. I'm aware that there are, for some tumor types, they're running. And so I'm afraid that it has to be, the idea is there, and we need, I guess, money and exposure to have it implemented and validated. And there are some programs running, I know, I'm aware of, but it's not routinely yet, unfortunately.
Yes, I think the same in the UK. It's not routinely available at the moment. I think we do need to understand a little bit more, and I think Nori may cover this in her presentation, about whether we can 100% rely on that and obviate the need to do a tumor biopsy. So currently it's still available through clinical trial protocols. Sometimes this is in early phase. So the target study, for example, looking at potential targets for early phase trials. And it will be something that is integrated into the Sapphire ABC10 study, which will be opening hopefully in the not too distant future.
Okay, another question.
We're all very aware of the recurrence rates in our surgical populations, many of whom will carry these mutations. So in your future of precision medicine, do you see these drugs being rolled out to the adjuvant setting?
Yeah, I raised the question myself, so in my presentation, and that's a very difficult one, because what do you do? I suppose the most important part of the mutation analysis is the prognosis. So let's say for patients with a, let's say IDH1 or FGFR2 mutation, they have generally a better prognosis. So you're more keen to go and search for, yeah, we'll still go on, even though it's a tricky case, let's say, because the prognosis is good enough to go for it. That is a potential use for the targeted treatment that can only be done in a clinical trial, because these drugs are registered for advanced disease. And to run a clinical trial in a neoadjuvant setting based on mutations, that is a worldwide study with a very interesting design, which I guess is a huge challenge.
I would direct you to the poster, Valerie Crowley's poster at lunchtime in the room just along the corridor there, to answer your question, Hans Josef. Great.
Well, you can answer it now.
No. You have to go and do the work. Okay.
You have Julien there.
Sorry, Julien.
Yes, just another obvious comment, but it was partly addressed, but I think it's very important to discuss that in this AMMF conference, is the difficulty sometimes to access to drugs. We know some patients with identified molecular alteration. For some of them, there are inequities across Europe to how we can deliver, or how is it reimbursed. Even some drugs with quite clear demonstration activity. For example, in France, NTRK inhibitors, which have shown very high response rates, are not reimbursed because French regulatory authorities want to have a randomized trial for NTRK, which is very rare, and they want every type of site to have a randomized. So we will need to randomize biliary tract cancer with NTRK versus standard of care, which is completely infeasible. And I think it's very important that patient advocacy groups raise this question with the regulatory authorities, how we can deliver in rare cancer, rare abnormalities, what level of evidence is required for reimbursement, and we can't do what is feasible for all comers. Lung cancer is not feasible for rare cholangio alterations.
And
Yeah, if I may-
linked to that, maybe the story of the FGFR trials in the first-line setting and what you think we can learn from that.
Yeah, if I may add, I'm sorry from Julien. So I presented the drop study approach. So what it is that there are like 35 drugs available, and there was negotiated with the pharmaceutical companies, and on basis on all cohorts in phase 2 studies. So we're not only giving the drugs to the patient, but we can learn something from it, and I guess that's what we need, because if we only just make the drugs available, then we might have a problem further down the track, because then we realize maybe it's not as efficient as we wanted it to be, apart from NTRK, of course. But that, I guess, if we can extend that program from the Netherlands to other countries, and again, it's an initiative from doctors in collaboration with pharmaceutical companies in a clinical trial, that would be, I guess, ideal. But
Yes, so the example that Angela was raising is that we've got evidence from the FGFR inhibitors that you've got high response rates and the durable responses, and the approval is conditional on then having a randomized phase 3 trial. And so the 3 drugs, if you look at the trial designs, were all very similar: first line cisplatin gemcitabine versus FGFR inhibitor. The number of patients needed to deliver all 3 trials was over 1,000 patients. So this is a rare cancer and a rare subgroup. It is just not going to be feasible to deliver that. If we just take one step back, the whole point of a randomized trial is that you don't know how your control arm would behave. And maybe what we need to be thinking is to understand a little bit better, how do we define how that control arm behaves, and to be able to provide context, do some work about understanding historical controls. Patients who maybe did have the mutations but then didn't have the treatment, how did they do? So I think we need to be challenging the paradigm of always doing the randomized trial, which was obviously largely developed around kind of chemotherapy, to now look at how do we apply this in the era of precision medicine.
fully agree.
Yeah, there are several questions. One is, I think it's important, it's I'm cancer-free right now. Should I still get the testing? Probably not received before the diagnosis. My oncologist says it's too expensive now, and only do it when the cancer is back. So, Juan, you mentioned a bit during your presentation, but I think it's an important point.
So just making sure that I understand the question, if somebody is cancer-free, I assume that they've had curative surgery and completed treatment. So at that stage, I think treatment can be considered complete, and we do know that although patients can recur, there are many patients who remain cancer-free, and there are patients in this room who can attest to that. The evidence that we have for how effective the treatment is when we do have evidence of disease. So currently we wouldn't recommend having it as a just in case.
Okay. Lots more. My mum was told the second biopsy was not possible, even though the first wasn't enough to test in the UK. How can the UK improve on this?
Yes, so sometimes it really is just not possible, okay? And
It's not
so,
a UK problem.
yeah, it is a global problem.
It's a human problem.
And so let me give you an example of why it may not be possible. You know, sometimes in order to get to the cancer, it's very, very deep inside the liver, so you'd have to go through the whole of the extent of the liver, and the amount of tissue that you're after may be a strip along a bile duct rather than a round lump, or it may be sitting on a blood vessel. And what you're then asking a radiologist is to put a needle in and make sure you get enough tissue for molecular profiling, but don't hit the blood vessel, because that could be life-threatening. So sometimes it really is just not possible to do that. And I think this is where we're looking to liquid biopsies and Dr. Starling's presentation to see whether that can come to our help.
And maybe just to put it in other words that makes it more easy to understand. Yes, it is actually always possible, but no, we don't do it because your life will be threatened by trying. And that is actually what is more acceptable, I suppose, for patients.
Okay. We're way out of time, but last question, please.
This is outside of my area of knowledge, so it's probably a very naive question, but I know that in lung cancer, for example, the mutational signatures can link back to cause because they highlight the chemicals that cause it. So can the mutational signatures here link back to cause?
So I think you're talking about kind of the non-smoking lung cancer.
Well, I was thinking about for the smoking lung cancer, it links directly back to the...
Understood.
Yeah.
Understood. So currently, as far as I'm aware, there's no direct link that will be able to identify the cause based on the mutations that we have. Remember that we're seeing slightly different patterns anyway. We do know, for example, that in liver fluke associated, you're more likely to have KRAS mutations, but that doesn't mean that everybody with a KRAS mutation has got a liver fluke associated cholangiocarcinoma. So currently, with the biomarkers that we have, the link is not strong.
And it is difficult to find the cause in the first place. So for some patients, it's easy to understand what sort of cause there is for this disease, but for a lot of patients, we have no idea.
Okay, great. Thanks very much, guys. Excellent session.